topic. So that's why we actually added it on, which was, the basics of all the procedures for CHD. So I've made it into a quiz format. So hope you've all had your coffee and please be ready with some of the answers. So we'll get started with some of the simpler ones. ASD. So when we talk about surgical procedures for ASD, can you name the types of surgical procedure and what access is used for surgical closure of ASD? So how do you close the ASD? What type of material do you use? What is that? And then what is the access that is used for ASD closure? Anyone? Anyone wants to take this? No? I see some new names in there. So don't be nervous to eat you up. I'm too far away to eat you up. So just enter, how do you close? What is the procedure for closing an ASD surgically? So one is you could put a patch. Yes, you can do a pericardial patch. Or you can do, if it's like, you can just do direct closure. If it's like this, then you need to put a patch, which could be pericardial or Dacron, right? So you have those two options. Now what about, so this picture here is of a patch closure. So remember, it could be pericardial, it could also be Dacron. And what is the access you can use for ASD closure? So we know you can do a stenotomy, right? So you can go midline stenotomy. Any other access for ASD closure that you know of? So minimal access would be via a lateral thoracotomy. So you have both these options for ASD closure. Nowadays we do something which is called mini stenotomy. It's something it's good to talk to your surgeon about. So not all surgeons are able to do the lateral thoracotomy. But if you do the stenotomy, but do it through a small incision, so that, when you, for girls, you wear a blouse, then you don't see the stenotomy incision high up. So mini stenotomy or lateral thoracotomy for having smaller incisions. Okay, VSD. What is the procedure for closing a VSD? What is it called? What type? What do you use to close your VSDs? And typically, do you close it from the RV side or the LV side? So what do you use to close your VSDs? You put a patch typically, right? What is that patch made of? So that patch again can be made of Dacron, can be made of calcium. Now it's typically put on the right ventricular side. Now what is the typical access for closure of VSDs? When you go in, you're going on bypass, right? How do you access it? Through the right atrium, the pulmonary artery, through the aorta, through the right ventricle? How do you access a VSD? Anyone want to take that? How do you access it? So it depends on the type of VSD. Yes, so it could be, you could do a transatrial through the right atrium in your membranous VSDs, inlet VSDs, right? You would do a transpulmonary through the pulmonary artery in which type of VSD? We go through the pulmonary artery in which one? In a subpulmonic VSD. And sometimes you go through the apex. In a which type? When would you go through the apex to close it? If it was through an apical ventriculotomy, if it was a apical VSD. Now, if you have multiple VSDs, or if you have an AV canal and a small baby, what would be the procedure you would do? If it's Swiss septum or AV canal and a small baby, what would be the procedure? And you could do a PA band. So you reduce the flow to the lungs to drop the pulmonary artery, so the baby doesn't get Eisenmenger's while you wait. And then when the baby is a little big, you tackle the AV canal, or once the VSDs, some of them have gotten smaller, you tackle the remaining ones. Okay. Now, you use Dacron, as I said, or a pericardial patch. and you close it from, depending on the VSD, from the right atrium. Is everyone understanding this part? So if it's in the membranous septum or inlet septum, you go through the right atrium, right, and across the tricuspid valve and close it off. If it's subpulmonic, you open the pulmonary artery and through that you close it. And if it's near the apex, that's very hard to go through the tricuspid valve and down, you can use an apical ventriculotomy. Now name 4 surgical procedures for coarctation repair. Surgical procedures for coarct repair. So name a few surgical procedures. Any that you've heard? Is everyone a first year fellow? So resection and end-to-end anastomosis, okay. Any others? So subclavian flap plasty. Yes, any more? So you can have, yes, an end-to-end where you cut, remove the coarct part and anastomose them again together. Subclavian flap, patch aortoplasty or jump graft. So if you see this first one here where this arrow is, the one here on the right hand side, is your end-to-end. You've just taken out the coarct segment and connected the together. This one down here on the right is your subclavian flap, where basically you take the subclavian artery and turn it down and use the subclavian artery to patch on your coarct. This one in the middle, patch aortoplasty, not used much, but basically use a patch to open up the aorta. And what is the downside of patch aortoplasty? What is the complication with patch aortoplasties? Anyone? Complications with patch aortoplasty? And which is why it's not done, is you can get aneurysms, because that is, remember the aorta is a high pressure zone, right? So you put a patch there, it's not as strong as your intima media adventitia of a normal aortic valve. So with over time, these can develop aneurysms, and that's why patch aortoplasty is really a last resort. And then this one on the left is a jump graft, which is also pretty much a last resort. So your end-to-end or extended end-to-end. What is end-to-end is basically when it's a narrow segment. Extended end-to-end is if it's a longer segment, you kind of have to also bring the two ends together. So that's why it's called extended end-to-end. So this is the most commonly used one for coarctation repair. Now, when we talk about subclavian flap, which age group do you use the subclavian flap procedure in? Which is the age group where you can do subclavian flap? So end-to-end, if you think about it, you can do it pretty much in any one, right? So which age group would you use subclavian flap in? Anyone? Subclavian flap can only be used in? No, not above 10 years. The answer would be it can only be used in neonates or early infancy. So think about it. You're taking the subclavian artery, right? It supplies the whole left arm. You're taking that subclavian artery, you're turning it down to repair your coarctation. So what happens to the blood supply to the arm, right? There's no subclavian artery left for your arm. So if you take down the subclavian artery in an older child or a teenager or an adult, what will happen to that arm? They will get acute gangrene, right? So the subclavian flap therefore can only be done in neonates or early infancy, because at that time they can develop a collateral flow and that they will not have developed gangrene of that arm. Is that clear to everyone? Any questions on this? Do you mind putting this light on? It's dark. So that's with the subclavian flap. So end-to-end can be done at any age. Okay. Subclavian flap, it's only in neonates and infants. Patch aortoplasty is really done when it's a very long segment coarctation. You can't do end to end. So long segment coarct in an older kid, you can do patch aortoplasty or a jump graft, but again, not recommended. So subclavian flap, neonates or infants, and just, hope that they your procedure in tetralogy of Fallot. What are the things you need to know in order to decide what type of procedure to do in tetralogy of Fallot? Anyone? What determines your procedure in tetralogy of Fallot? So it's going to be the Z-score of your pulmonary valve annulus as well as the size of the branch pulmonary arteries, right? So the size of the branch pulmonary arteries and the size of the pulmonary valve annulus. And yes, your coronary anatomy has to be suitable for the correction. So when we talk about the Z-score of the pulmonary valve annulus and the PA anatomy, it's important with the pulmonary artery anatomy to define what is the Magoon ratio. So Magoon ratio is, what is Magoon ratio? Anyone? You can see it here. It's your right pulmonary artery. The diameter of the right pulmonary artery taken at the pre-branching. You see how you take it pre-branching? So here you take it before it branches, plus the left pulmonary artery pre-branching, divided by the descending aorta diameter at the level of the diaphragm. So you need your normal value is more than 2. Less than 1 is also obviously very hypoplastic. So really to do a total correction is better if the Magoon ratio is more than 2. If it's 1.8 and above, you can do it. If it's less than 1.5, it's small. 1.5 to 1.8, you're in the borderline range. So you need to know what is your Magoon ratio and what is your pulmonary valve annulus. Now let's just look at these CT images. And I want you to tell me, now let's start with this one here on the left. Here, what is the diagnosis? What do you think of the pulmonary arteries here? What is going on in this case? In this patient here? What is happening with the PAs? What is happening here? This is the right pulmonary artery. What is going on? You've got an LPA mid-stenosis right here, right? So the original origin of the LPA is small here. Distally, it's good size. So this you could actually, because you've got a distal branch PA is good size, you could patch open this LPA. So in addition to whatever you need, you'll need to do LPA plasty. Now let's look at this one here. What do you think of these PA sizes? What do you think? Just eyeballing it. They're good size, fair size, small size. These ones. These look good size. Now what about this one? What do you think of this pulmonary artery anatomy? These are hypoplastic. So you see, you get a sense just from eyeballing also whether it's good size or hypoplastic. But it's good to have also your Magoon, your Nakata index so that you're a little more scientific with it. Because sometimes one surgeon will say, oh, that looks good. Another guy says, that looks small. So when you have clear data, it becomes a little easier for you to plan. Similarly, you measure your pulmonary annulus, calculate the Z-score. So now let's go over the management. Now you have if the pulmonary arteries are small and it's not suitable for total correction, you're going to do a BT shunt, right? Actually a BTT shunt. So this is a good movie for all of you to watch. It's called Something the Lord Made. It's a movie on the first Blalock Blalock-Taussig Thomas-Shunt. And it's a very interesting movie. You can download it maybe on YouTube. Something the Lord made. It's a 2004 TV movie. So please do watch it. So these were the three people who came up with the BTT shunt. Now, what are the types of Blalock-Taussig shunts? What are the two types of BTT shunts? So classical and modified, right? Now, a classical BT shunt is where you are using the subclavian artery, and the big advantage is you're not using any prosthetic material. So in a classical BT shunt, you take the subclavian artery, turn it down, and attach it to the pulmonary artery. What do you do in a modified BT shunt? The subclavian artery will supply the arm. So here, if you've got, this is your subclavian artery, right? And this is your PA. Now you see here, you've taken the subclavian artery here and turned it down. So this is classical. Again, in which age group do you do classical BT shunts? In neonates. Because you see again, you can't just turn down a subclavian artery in an older child. If a 5-year-old comes to you for a shunt, you're not going to do a classical BT shunt. Same philosophy as we discussed with the subclavian flap. You can only turn down or use the subclavian artery in a neonate or a very young infant. So that's classical. Now the modified would be, if this is your subclavian, that is your carotid going there. So this is your innominate artery. Your modified would take what material? From the base of the innominate, take a material down. So it could be PTFE. Yes. It could be Dacron, right? So you look at this CT image down here. You see here, this is your BT shunt in there that you can see. It can be a Gore-Tex tube, right? So you can use any of those to do your modified BT shunt. So in a classical BT shunt, you are taking the subclavian and turning it down, right? What is the disadvantage? One advantage is it will grow as the baby grows, right? What is the disadvantage of a classical BT shunt? Could be limb growth, but as I said, you are going to mainly do it therefore in neonates and young infants, right? So you have one challenge, which is limb shortening, like we discussed with the coarctation. And that is why you're going to use it only in neonates and infants. One big disadvantage is in case you get, they don't get collaterals. You can land up with ischemia. And remember you do the test for your radial and ulnar and you look and see if you've got enough collateral thing. Now imagine when you just take off a subclavian. There are those rare cases where they really are unable to get collateral flow and you land up with getting limb ischemia acutely. It's quite unusual in neonates, but can happen, and that's why classical is only done in neonates or young infants and not in older age groups. Advantage, of course, is there's no prosthetic material. The chances of clot and thrombosis are less, and it's a relatively easier. You already have it. It's relatively easy to turn it down and get it done. Flow is very good. In fact, sometimes flow is too much through a classical shunt because it's limited only by the mouth of the innominate artery, and it can grow as the child grows. So it definitely has a lot of advantages. Biggest disadvantages, ischemia, and of course limb shortening or not growing as much with the child and having limb length discrepancies. So only use of classical is in neonates, early infancy. Okay, all clear on this? So now the surgical option, right, for tetralogy of Fallot, the total correction would be VSD closure, right? You close the VSD and you have to open up the pulmonary stenosis. So what are the two types of open heart surgical procedures for tetralogy? What are the two types? What are the two approaches? So one is, what is this one? This picture down here is what? See here, what are they doing here? So this is a transannular patch, right? So this is a transannular patch where you cut across the pulmonary valve annulus. That's a tap, right? Transannular patch. What's the other type of repair? The other type, there's no transannular patch. So what is that repair called? That is called a anyone? What is that repair for tetralogy of Fallot? Is transatrial, this one, where you go through the right atrium, across the tricuspid valve, into the right ventricle, and you remove all the RVOT muscle, but you don't cut across the annulus. So which one do you think is better? Transannular patch or transatrial repair? Which do you think is better in the long term? So transatrial, right? So transatrial is going to be better because you're not cutting the ventricle, you're not cutting the pulmonary valve, right? So you have less incidence of arrhythmias. You're not cutting the pulmonary valve annulus, so you don't have pulmonary regurgitation long term. So long-term issues of RV dilation, needing pulmonary valve replacement, all those issues are not there with a transatrial repair. So when you talk about open heart surgical option for tetralogy of Fallot, it is either a transannular patch, what we call transventricular, or it is transatrial, no transannular patch. We decided transatrial is the better option, right? Because with a TAP you have PR, RV dilation issues, need for pulmonary valve replacement in the future, higher incidence of ventricular arrhythmias because you're cutting the right ventricle. Why is it that we don't do a transatrial repair in every baby? How come transatrial we've decided is best? Why are we not doing transatrial in every tetralogy of Fallot? Because it depends on the pulmonary valve annulus, right? So that is why I said in the beginning, the management of tetralogy of Fallot depends on two things, pulmonary artery anatomy and pulmonary valve annulus. So, if pulmonary arteries are small, what is your treatment? Pulmonary arteries are small, your treatment is BT-shunt. If pulmonary arteries are adequate, next you look at pulmonary annulus. If pulmonary annulus is adequate, what is your treatment? Transatrial repair. If pulmonary valve annulus is small, your treatment is transventricular repair. So you see how knowing the anatomy and knowing the pulmonary valve annulus will determine what type of procedure you do. So what is a one stage versus two stage? One stage is total correction, two stages, BT-shunt first followed by total correction. So if the pulmonary arteries are good sized, coronary anatomy is suitable meaning you don't have anything crossing in front of the right ventricular outflow tract where you're going to make your incision, then you can do an ICR at any age. If pulmonary arteries are small or you have a coronary artery crossing the RVOT, this applies of course only to patients where you have to do a TAP. When you're doing transatrial repair, you don't care about the coronary artery because you're not going and cutting in front of the RV. Only when you're doing a transatrial are you fine. If not, if you're doing a TAP, coronary artery makes a big difference. So if PAs are small or there's a coronary artery crossing RVOT, you do a BT-shunt followed by an ICR or a homograft later. That is your two-stage procedure. Okay, all clear on this? Now, what is the diagnosis here? This is a echo-wise tetralogy of Fallot, but you see this on CT. What is your diagnosis? So, TET absent valve, right? Because you see very dilated, you can all see these dilated pulmonary arteries, right? So, very dilated branch pulmonary arteries here. And what is happening here? What are you looking here? What is going on in this CT? So, this is top absent pulmonary valve. What is going on in that CT? So, there is bronchial compression, right? You can see here, you see this? how this is compressed. This is the normal airway here, and then you see that you're not getting anything here. So there is bronchial compression. So what is the treatment of TET absent valve? What is the surgical option with TET absent valve? So RV to PA homograft, okay, and tell the total surgical. What are you going to do? VSD closure, right? And RV to PA homograft and reduction plasty of PAs, right? So that is the total correction. Now some people will do VSD closure and valvotomy or a transannular patch. They will treat it like a regular TET. But the disadvantage is you will have PR, and you have all the issues of PR even continuing later. So ICR with PA plasty to remove bronchial compression, ICR with homograft placement. These are the two options that you have. Now, we'll move on to Ebsteins. What is the surgical procedure for tetralogy, for tricuspid regurgitation in Ebsteins? So I'm not going to go, in Ebsteins, it's a fairly complex decision making, and we will discuss that when we do Ebsteins as a lesion. But when you talk about the TR and Ebsteins, okay, so you have the cone repair, anything else? So in Ebsteins, let us say you only have an ASD. You may need to only close the ASD. If you have an RV that's hyperplastic, you may need to add a Glen into your treatment plans. But if your significant issue is TR, then you're going to have to fix the tricuspid valve, and it's important for us to know all the different options. So you've got the Danielson, okay, which is basically putting a monocusp and repairing the ATL, and all of them involve some kind of plication of the right ventricle. Then you have a Carpentier, and you don't need to, as PD cardiologists, at least know all the details, but you need to know there are multiple options. So in Carpentier, you detach the ATL, and then you rotate it and create a valve and reposition it. And then you have your De Silva cone reconstruction. And that is now the reason you all know cone, which is very good, because that is the latest treatment now for Ebsteins, where you actually take out, you delaminate all the leaflets from the myocardium, you mobilize them all, and then you reposition them. Whereas in the previous ones, they would only really work on the ATL, on one of the leaflets. So these are the three different Daniel cell, Carpentier, and De Silva cone reconstruction, the three surgical procedures for tricuspid regurgitation in Ebsteins. Okay, we'll move to D-TGA intact septum. What does the surgery depend upon? D-TGA intact septum. So it depends on LV, whether LV is regressed or not. Okay, what else? So whether LV is regressed or not depends upon, typically on age. We used to also, surgery would also depend upon coronaries, but less so. I think any, coronary now the surgeons can handle. So it really depends upon your LV, regression, and age. So till what age would you, without thinking, go ahead and do, what is the operation for D-TGA intact septum? What is the surgery for D-TGA intact septum? So arterial switch, okay, so the ASO. So you're going to cut your aorta, cut your PA, put the aorta here, put the PA there, translocate the coronaries, right? So till what age? You will not ask LV is regressed or not, and you will just do a switch. So some people, 6 to 8 weeks, 8 weeks, it depends on your center. Definite, everyone will agree till 4 weeks. That they are not going to ask questions. Even if it looks pancake, anything, they will do switch. Some centers say even till 6 weeks they'll do a switch. Some say till 8. But if you say 4 weeks, every center will agree till 1 month of age, they can directly do an arterial switch. After 1 month, if the LV is regressed, then what are your options? You can either do a Senning or you can do a two-stage arterial switch. So what is the first stage of the two-stage? What is the first stage of the two-stage arterial switch? So the first stage is you want to prepare the LV, right? Because it's a non-regress. So now, if you just do a PA band, tighten the PA here, right? Yes, the LV pressure will go up, but what will happen to the baby? What will happen to the symptoms? Baby is already blue. It's TGA intact septum, he's very blue. Now you banded him. What will happen? He'll become more sinuous. So typically the first stage of the two-stage is a PA band plus a BT shunt. Or a PA band plus BT shunt, or other, yes, is a non-surgical option of just stenting the PDA. Because if you stent the PDA, you are increasing the pressure in the PA by causing pulmonary hypertension, and that pulmonary hypertension will also make the LV become thicker and LV mass improve, and LV become capable of, when you do a switch, pumping to the aorta. So all clear? So if the LV is regressed, then you do a two-stage switch or a stenting, which is your atrial level switch. Okay, what is the Rastelli procedure and which lesion do you use it in? I'm not going into details of each lesion today because this is just an overview of all surgical procedures. So Rastelli is VSD closure in a way that routes LV to aorta, right, and RV to PA conduit, which is the typical lesion Rastelli is used in. DORV, VSD, PS, TGA, VSD, PS. So typically in TGA, VSD, PS. So you're going to connect up your LV to the aorta. So yes, I guess you could call it in truncus. I mean, typically truncus, yeah, you could call it Rastelli. That's also fine. It's not exactly, but nowadays Rastelli means really anything where LV is getting routed to aorta and RV is going to PA through your homograft or through your conduit, right? But typically this was first described in TGA VSD PS or DORV VSD PS, DORV VSD pulmonary atresia. Okay? What is REV procedure and which CHD is it used in? What is REV? What does it stand for? What is it? PRT means? What is PRT? Ventricular and MPA connection using a patch. Okay. And which heart disease do you use it in? Yes. And which heart disease? So this can also be used in TGA VSD PS, can also be used in DORV VSD PS, right? So this is the French word. You got most of it there. So reparation attache ventricular. So if you see here, you've got aorta coming from the RV, PA coming from LV, so it's a TGA. It similar could be DORV, VSD and PS. But in this, either you can do a Rastelli, right? So if you were to do a Rastelli, what would you do? You would connect LV to aorta here and you would put a homograft here. So that would be your Rastelli. But if you did the Rastelli, what would happen? As the child grows, you will need to replace the homograft. So the other option that's been devised is you connect your LV to aorta, right? You take your PA. You actually need to do it so you cut the aorta and bring the PA forward, okay? And then you reanastomose the aorta here. Now you bring the PA forward and you patch the PA directly onto the RV. So you are doing this without a homograft. So the simplest way to think of it is that the PA is brought and attached straight onto the right ventricle without a homograft. The downside is there will be pulmonary regurgitation, which generally, like the tetralogy always has PR, so you will have PR. So it's not a good option when you've got, say, pulmonary hypertension. If you obviously have a DORV VSD PS or a TGA VSD PS, there is PS, there's no pulmonary hypertension, this is a good option. So nowadays, instead of doing Rastelli in smaller kids with TGA VSD PS or DORV VSD PS, REV is a very good option because it avoids homograft. Therefore, this becomes your one-time fix. Okay, all clear on this? Okay, what is Nikaidoh procedure and which CHD is it used in? So if you go back to this picture here, right? Here, you see this is a rootable VSD, right? LV is rooted to aorta. So you can do a Rastelli, you can do a REV. So yes, so Nikaidoh is basically a root translocation which is used in anatomies where you can't do a Rastelli. For instance, if you have a remote VSD, or so if the VSD is located away from the LVOT, so you can't root the LV to the aorta. So what do? You take the root, right? You take the whole aorta and you move it and patch it onto the left ventricle. You bring the pulmonary arteries forward and patch those onto the RV. So the difference is here. So in this, if you see, you're taking the pulmonary artery and patching it onto the RV. You see here, this is the final. So that is similar to your REV. But you're not able to root your LV to aorta like you do in a REV. So what do? You disconnect the aorta, you transect the aorta here, and then you patch that aorta directly onto your LV. So if you say, imagine you've got an LV here and you have an aorta here, you can't root it. So non-rootable VSD. So you take your aorta and you plonk it here. You take your PA and you put it on the RV. So it is aortic root onto LV and pulmonary artery onto RV. Now it may be you need to do a conduit to the PA, either a patch or a conduit to the PA, that depends on the anatomy. But what defines the Nikaidoh is really what is called aortic root translocation. You take the aortic root and translocate it onto the left ventricle. It is used in non-rootable situations where LV cannot be rooted to the aorta, therefore precluding a Rastelli procedure. All clear on this? Okay, we'll move on to next. Yeah, I know it's hitting 7. Tell me when I should stop. But pulmonary atresia VSD, treatment depends on what? What determines treatment in pulmonary atresia VSD? Two things. So PA anatomy is one. Next. One is pulmonary artery anatomy and second is collaterals. So these are the two things that determine your surgical options in pulmonary atresia VSD. What is the PA size and what is the collaterals? So if you've got confluent branch PAs, right? If they are small, what do? If you have confluent branch PAs but they are small, what is the treatment? BT shunt, right? They are small, you do BT shunt. If you have confluent branch PAs and they are good sized and not collaterals are not many, what do? They are good size, they are supplying most of the lung fields. This is a slight simplification of pulmonary atresia VSD, but anyway, just so you get, you understand conceptually. So if they are good size, what is you're going to do? Complete repair. What is that? What is the complete repair? What is complete repair in pulmonary atresia VSD? It involves VSD closure, then what else? RV to PA conduit, and collaterals. You have to figure out what to do with the collaterals. So, unifocalization. So, if you have adequate PAs, you will do a Rastelli with unifocalization. If you have non-confluent PAs, do you all understand unifocalization? So just to explain, let us say you've got PAs like this, whatever their size may be, right? And they are supplying, let's say, 6 of your lung fields. They are supplying here, here, and here, and maybe they're supplying middle lobe, maybe they're supplying part of lower lobe. And let's say the upper lobe is supplied by collateral, and this upper lobe is supplied by collateral, and this lower lobe part is supplied by collateral, right? If you just do a Rastelli and do a homograft to here, you're only going to be giving blood from the RV to some segments of the lung. So unifocalization means we take these collaterals and we connect them up to the pulmonary arteries. So we make now these collaterals get disconnected from the aorta and they get connected up to the pulmonary artery. So the collaterals now become part of the pulmonary vasculature. And why is it important to do this? If you leave the collaterals connected to the descending aorta, one, there may be high pressure, so you may get vascular damage in that segment of lung. Two, when you have collaterals getting high pressure from the aorta, you may get a bleed in the lungs, right? So you have the issues of the collaterals. So in pulmonary atresia VSD, whatever you do, if you're doing BT shunt, typically you will do BT shunt with unifocalization. If you're doing Rastelli, you'll do Rastelli with unifocalization. Now, this is one lesion which you have to really personalize. Then you're going to do a, what? Audio went again. So non-confluent PAs with NAPTAs, what are you going to do? Anyone? Non-confluent PAs? Then your only option is to unifocalize and either put a homograft or put a BT shunt. Some, you have a combination. Some people you put a homograft, leave the VSD open, keep the homograft small, later on close the VSD. There are multiple options that you can try. So if you have non-confluent PAs, your answer is going to be unifocalization with either a BT shunt or a small-sized homograft or a Rastelli. Okay, all clear on this? Diagnosis here, CT scan. What is the diagnosis? So ideal age for unifocalization, that's a good question. The ideal age for unifocalization is in infancy, because the longer you leave the collaterals like that, they get stenosis within the collaterals. It becomes harder to unifocalize as you get older. So ideally, you should unifocalize in infancy, connect them all together, put a small homograft or a BT shunt, and if you put, so now the issue is, this is the issue. The ideal age is infancy and we should do all that. The practical problem in India is, even if you do it in infancy, they will always need redos. So if you do in infancy and you put a homograft is good because you can go antegrade, you can balloon up those collaterals, you can keep the child going. But you have to put a larger homograft as the kid goes and a larger homograft. If you put a BT shunt with unifocalization, you have to change it to a homograft and then a larger homograft. So that is why in India you will see most centers don't unifocalize in infancy. In the US, yes, they will unifocalize, they will put homograft, they'll change the homograft every 2-3 years. I followed a kid when I was a fellow at Yale who had 18 surgeries for homograft rechanges. But in our setting, is that practical? That is the issue. Because it's not practical, because it's expensive, because families don't want to put so much effort into 3, 4, 5 surgeries, we'll end up delaying and delaying and delaying till they're bigger so we can get a bigger size homograft. And all said and done, outcomes in pulmonary atresia VSD, long-term outcome survival is only 50%, no matter what you do, which is why here you will find in most centers a hesitation to rush in to do unifocalization, which is based on a lot of practical considerations. Okay, so this one, anyone, diagnosis here on this CT scan? So this is, you see these, so good, that's an infracardiac PAPVC. You can see the pulmonary veins coming, right? And then you have a vertical vein going down, 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 and it will enter into the hepatic system and then come back up. So what is the treatment for PAPVC? Treatment for TAPVC? Oops. Oh. So, rerouting the pulmonary vein to LA and ligating that vertical vein. Remember that vertical vein should also get ligated. Otherwise, sometimes it's a pop-off for the pulmonary, for the common chamber. So, the treatment of PAPVC is, you take, if these are your pulmonary veins, right? They were coming back like this, and this is your common chamber. It's not connected to the LA, right? So this is your LA here. So you are going to go to the back of the LA, posterior part of LA, and create an opening between the common chamber and the left atrium. So the common pulmonary vein is connected to the posterior wall of the left atrium. ASD should be closed off, vertical vein should be ligated. Okay. Treatment of truncus arteriosus. Treatment of truncus arteriosus. Anyone? Treatment of truncus. So the pulmonary arteries, you're going to close the VSD in such a way that the LV is going to the trunk so that it becomes LV to our aorta, and you put a conduit from the RV to the PAs. Yes? Yes, plus or minus truncal valve repair. Now, is there any operation? So, valve homograft from RV to PA with VSD closure. And you're going to have to redo the homografts in the future as the baby grows. Now, is there any surgical option for truncus that does not involve a conduit? So, your PAs are coming here, right? You took them and you connected them by a homograft, right? So, can you, yes, so you close the VSD and you don't want homograft, you can take the PAs and directly put it onto the RV. But can you connect, which type of truncus can you do that in? Only in type 1. So in type 1 where you have kind of a main pulmonary artery, kind of, which is then branching, right? You can take it and take that MPA and directly put it onto the RV. It is not called a rev, though I understand what you're saying, it is like a rev, but what is that operation called? That operation was first described and is called by the name of Barbaro-Marcel procedure. It is like a rev, but it's given the name of Barbaro-Marcel. It's used in type 1 truncus, or type A1, and can really only be used in neonates because once you put this, there's no valve, so there will be PR. So if you do it in an older kid who's had pulmonary hypertensive, has pulmonary hypertension, pulmonary vascular damage, you have a risk of high pressure PR and RV dilation and early need for pulmonary valve. So older kids, it is better to put a homograft which has a valve, not a non-valve by the way, a valved homograft. In neonates, where PA pressure, PVR will drop immediately after procedure, you can go ahead and do a Barbaro Marcel. Okay. I think I shall end with this. This is, Glenn and Fontan that I think you all see, all the time, so I won't discuss that. So this is just a Glenn, SVC to PA. The types of Glenn, pulsatile or non-pulsatile. You can have left Glenn, right Glenn, bilateral, bidirectional. And bidirectional basically means that the SVC gives blood to both the right and the left branches. It's connected. In the past, they used to do unidirectional, which meant SVC only went to RPA. But nowadays, we don't. All Glens are nowadays bidirectional. And similarly, for Fontan, this you can see here, cross-section of a Fontan, which is IVC to PA. And the two types of Fontan, as you know, are lateral tunnel and extracardiac. So lateral tunnel goes inside the right atrium, extracardiac goes outside the right atrium. Extracardiac is a laminar tube, therefore has less chance of arrhythmias and hopefully less chance of clot. Lateral tunnel has a part of it is the wall of the right atrium. There's more suturing around the right atrium, so more chance of arrhythmias long term with the lateral tunnel. So I will end with that.